right. Hi, everyone. Good afternoon. Welcome to Under the Boughs, Innovating for Populations. My name is Maura Little. I am the Executive Director here at Cambia Grove. Cambia Grove is a healthcare transformation hub focused on bridging the gap between entrepreneurs and the traditional healthcare sector. We are thrilled to be hosting tonight's event in partnership with the UW BioEngage program. It is now my pleasure to hand it over to our host for the evening, Lee Huntsman. Thank you.
Thank you, Maura. Good evening, everybody. Glad you're here. Made it through the monsoons. You might be in for a long evening. I don't know what's going to happen with the weather out there, but I can guarantee you an entertaining evening at the least. I want to reiterate our thanks to Cambia and the Grove and to BioEngage for sponsoring these sessions. And remind you that our goal is to try to understand what are the forces driving change in healthcare and what are the implications of these changes, as clear or unclear as they may be. What are the implications for the innovation community? How can we be constructive in the opportunity to move healthcare to a new and better place? And I'm thrilled that we have one of the architects of change in healthcare with us tonight, Greg Marchand.
Thanks, Lee.
Thank you for being here.
My pleasure.
You know, when I sat down to think about it, I made up a title for tonight, which is not the title we published, but I called it Purchasers as Provocateurs. And I want to bore into that a little bit, and this is one of our country's leading provocateurs from the purchaser perspective, and I think he has a lot to teach us about how do purchasers think, what's going on with them, and how are they using their position to try to achieve good change, and how's that going so far. But before we do that, Greg, how did you wander into this swamp? What's your background? And in fact, what is this global benefits job title here? What do you actually do?
That's a fascinating question. Well, that means setting our corporate strategy for anything related to our retirement plans, our well-being plan approaches, collective bargaining, healthcare, and then how we tie this all together for our employees and our businesses. So I don't really do much.
Right.
My
Yeah,
team,
I've heard that, yeah.
I know.
Yeah.
My team obviously does all the real work. And I try to focus on keeping a very, very talented team and partnering with our businesses to understand their challenges and how we do what we're accountable for better. And we have, depends on the interest rate, but $80 billion in pension liability, generally the largest employee savings plan in the country, $40 to $50 billion in assets, and then we spend $2.5 billion or so on health and other insurance costs. So we're measurable to our businesses.
And how did you get into this? Did you come up through HR or some other? What's your background?
Economics and business. Went to college to play soccer. And did that for 4 years, and then finally figured out that I needed to study and fell in love with economics, and then started to make these really interesting connections between an individual's health and the impact that has on health care and costs and the economic impacts of that. Got lucky enough to catch on with actually Boeing's medical department 20 years ago. Started by helping to develop our well-being programs. That's how we brand wellness programs. and then, moved into the benefits organization and kind of grew from there. I did mergers and acquisitions for 7 years at Boeing, which was a fascinating learning experience and really helped me understand how we manage risk from a business perspective, which helped me connect those things when I came back into the benefits world.
Fascinating. Well, of course, risk is an operative term these days in healthcare, isn't it? It's sort of shifting around the chessboard. Tell us a little bit about how you see the big picture. I alluded to purchasers, but it's because so often when we talk about healthcare, we talk about providers and patients and payers. But I've always had the notion that the people who write the checks, the purchasers, are an important component of the system that maybe doesn't get as much attention. But if we look at the media, we think everything going on in healthcare has to do with the individual insurance market and the politics thereof. But from a statistical point of view, employers insure half the population, and government another 40% or something like that. So
yeah,
what's going on in that big picture?
I think I'm besides beyond Medicare, I'm the largest contractor for ACO services in the country. Really? I don't really know if that's true, but I like to claim that that's true.
Well, yeah, absolutely.
Close enough. Thanks, Mary. Let me also really answer your question, though. It's really, really important that employers set business objectives and, are demanding. I view healthcare as part of my supply chain. And historically, we've defined a supply strategy for healthcare. And many of the things that we do are because they're in the best interest of our employees. But how we do that is in a way that leverages many of our business practices related to effectively partnering with the supply stream.
Well, elaborate a bit on that, though,
Sure.
Greg. I would have thought that for the vast majority of employers, healthcare is just a big troublesome entry on the liability side of their ledger. And you're saying it's more than that at Boeing.
Well,
what do you mean? It
is that. The biggest impact is actually to the productivity of our workforce. My goal as an employer is to always, pay for the right care at the highest quality, institutions where that can occur. It's not like a single price point issue to me. It's much broader. We have, the largest production facility in the world by volume. Does anybody know how long it takes? And if you guys don't know me, I love to ask people questions. So, and I know a lot of you. So, but does anybody know how long if you work up in our Everett factory, how long it can take to get off the campus there? It can literally take 20 to 30 minutes to get off the site if you have a doctor's appointment. Obviously, I want somebody to go get the care that they need, but when you're building a product, that's a loss of productivity. So if somehow we can either enhance that experience or find alternative ways for people to get what they need, that's a good thing, because we have challenges related to ensuring we have a highly productive workforce beyond just health.
Well, but let's bore into this a little bit. That means that from a ledger point of view, you not only have a negative, you have a liability entry for how much it costs. If in a virtual sense, you have an asset entry for a healthy workforce. a healthy workforce is a benefit. And so,
Absolutely. I mean,
now, how do you manage this when you're out shopping for healthcare, right?
Yeah.
Is it not just a matter of minimizing cost? It's you got some other things you're trying to achieve here. It sounds like.
I mean, absolutely not. I mean, I would much rather essentially pay more to have something that is better for the individual, that gets them potentially back to work faster, in a healthier, more effective way than, I mean, we look at very little from just an individual price point. I mean, that is one part of what we look at, but when we'll talk a little bit more about some of our ACO goals, but our goals are aligned to the triple aim, and we put as much, if not more, energy and focus into service and affordability for employees than just pure cost. And those of you that have worked with us, usually the first focus in anything we do is quality.
Well, so how does that actually work? I mean, traditionally, employers just turn to their insurance brokers and say, get me the best deal you can. And you're obviously doing something entirely different. You're much more proactive and involved. You have a more comprehensive set of goals you're trying to achieve. But how does that actually work when you're out there trying to purchase health care for your employees and their dependents?
We look at the roles of our supply chain probably a little differently than others do. It's interesting. When we started our ACO work, a lot of the first questions I would get is, are you going to need your health plan any longer? And of course. I don't want to contract with thousands of providers. I don't want to do customer service. I don't, want to take care of all the credentialing stuff. But we're really crystal clear on what we want from our health plans, and we want excellence in those areas. So to us, it's, looking at each component of the supply chain and really trying to drive excellence, no matter, what that role is. We're Blue Cross and Blue Shield of Illinois is, using, some of the highest tech whisper technology in, answering the phones, and hiring folks to provide service that have, in some cases, advanced degrees, because the goal is to improve the productivity of our workforce and provide a level of service that's not typically available. Now, I should certainly say that does everything we try to do work, and does it work perfectly? No, but we look at what we do as part of our attract and inspire strategy. I wouldn't have a job if we weren't trying to have the best, most talented workforce in the world. And so we try to leverage what we can do within, things within benefits to help differentiate. We're not going to differentiate. I have enormous respect for how folks at Amazon or Google or Apple attract folks. We're not going to be that. We still build products. That's why we exist. But we have to attract and inspire our employees in a different way that's effective for us. So that's really the first lens, and then we start to drill down deeper.
So you use those criteria and that style of thinking when you're talking to plans. But now you mentioned that you're also kind of trying some new things. This ACO arena that you've talked about.
I mean, I don't.
What's that about?
I mean, I don't mean this as a criticism to any health plan, but health plans don't practice medicine. They don't deliver care. Doctors and nurses and other clinicians deliver care. So if I want the health of my population to improve and have a more productive workforce, I need to have a relationship with the folks that are delivering care. I mean, I need to understand their business challenges, and they need to understand mine. I mean, I just had this fabulous discussion with somebody that at UW, not as part of our ACO arrangement, but just another part of UW. And they had no idea what my goals were, and so what we started to talk about is how could they help us enable a more productive workforce. So if I didn't have these relationships, how would folks know what's important to me?
Still, that strikes me as a significant departure from the way most employers work. If you want a relationship with your provider network, and you want to understand their business, their issues, and partner with them, that sounds novel and potentially powerful. Now, is the ACO your primary vehicle for doing that?
That is by far the most impactful. I mean, we've done a number of other approaches and pilots, and the one that I love the most is something we did related to primary care a number of years ago, focused on our most complex patients, and that was, the learnings from that were amazing, and we demonstrated improved cost, higher physician satisfaction, higher patient satisfaction, and a bunch of other good things. Scaling that and replicating that was really, really hard within our supply chain. There's a lot of doctors and hospitals in this country. We started to think much more holistically about where our relationships need to lie. As much as I love that work, and that we still, have a very, very big importance and priority related to extremely high quality primary care, we needed to look at things much more systematically. And I would say, we are probably a little more innovative than a lot of other employers, but I am seeing more and more positive, bright spots of other employers or organizations that represent employers doing more and more of this work.
So it sounds like we're in a season of experimentation, and you're down the road. So let's talk about the things that are being tried. And maybe even go back to your primary care example, because if I heard you right, you said you set up an experiment in primary care and you discovered there were lots of benefits. Now, scaling it turns out to be really tough, but tell us more about that. Was that a result of your criteria, a close relationship with the provider organization, or how did that experiment work? Because the impression we all start with is that the inertia in healthcare is almost overwhelming. It's so tough to do things differently. And you're saying, hey, we did an experiment and it had different results.
Lee, I think there's a lot of people that are very willing to innovate and partner and do things together. It does take, I mean, it is a partnership, and you have to be willing to find common goals. I mean, with our we call it IOCP, that project. I mean, we went out to the marketplace and went and visited with clinics that saw a large volume of our patients. And we ended up doing our pilots and our initial studies with Valley, Virginia Mason, and the Everett Clinic to kind of prove the concept. And we paid, we wanted a higher level of service, so we paid an additional PM on top of what folks were billing for claims in order to, get that extra level of service. The clinicians needed to make investments in people. Those things cost money. So there's a balance there. But in the end, there was a strong return on investment to us because they were helping us, problem solve and improve patient care and help people get healthier in ways we hadn't seen before. I mean, we saw, clinicians essentially doing, virtual rounds at, whatever time early in the morning related to some of our patients in order to figure out what the comorbidities were and how to manage it. And of course, we're not involved in that part of it. We just want to enable those things to happen. And it was completely the choice of our employees whether they wanted to participate or not. And that's the same approach that we take with our ACO work. Individuals can stay in the same health plans they've been in and or choose to participate within any of the ACO arrangements. We try to provide added value, which is what anybody wants. And think of it, I spend a lot of time trying to think about what's the purchaser, what's the experience? And can we, provide some bright spots to people that are, nuggets of fabulous service that make this better? And, holistically, have we solved this? No. Do I have, I could spend this whole time talking about fabulous service experiences that I've seen people get because we've got people that are focused on our population. And there is accountability across every part of the system in order to do that.
So let's frame for us a little bit about ACOs. If I hear you right, you're saying you've had a lot of experiments, you've done a lot of learnings, but am I right to say that then in an attempt to do it at a larger scale, you move to more of an ACO kind of structure, which covers a more comprehensive set of care than just primary care, and it's a bigger deal with bigger providers and more comprehensive. But do I remember right, you had a set of criteria when you were asking provider organizations whether they wanted to be an ACO partner? I recall you said you had a list of criteria.
We have we literally started out when we started this, because we were essentially first to market. There wasn't, at least in this community, there wasn't ACO products available at the time. We literally wrote down what our goals and objectives were, shared it with many of the, either clinical leadership or system leadership, and said, what are your goals? How do they align with ours? And do you see an opportunity here to work on this? But as part of that, we want more affordable care. We want to work on quality, and we want to work on service. All our goals were essentially aligned to the triple aim, and we had discussions about how do your goals align with ours. There's wonderful things of being first to market, And there's, you're taking, I mean, that's probably the most risk that we're going to take in something that isn't related to the products that we build. But it's been, I mean, it continues to be, I mean, I would be the first to admit, has everything worked out perfectly? No. Do I regret any of the things we've tried? No. I continue to look at this as just an incredible learning environment and incredible progress being made. I mean, we're seeing, and I won't make Rachel stand up and talk about their results, but from in the areas of quality that we're measuring, we're seeing improvements in almost every single area. Same thing with service. We've clearly made it more affordable to our employees. Clearly that's causing some challenges within the marketplace because the size of the risk associated with this kind of work. I mean, we knew that was going to be incredibly challenging. We have a long way ahead of us as part of this journey. But I couldn't be, in aggregate, more pleased with,
Well, so tell us a little bit more. And I think of the spectrum of financing for healthcare from fee-for-service to a capitated model at the other extreme. And your ACO model is where on that spectrum, would you say?
Well, I mean, the easiest way to describe the initial version was essentially taking on full risk for all components of care delivery. So, I mean, it's highly...
It's an easy shift for a provider, right? Just to go from fee-for-service to full risk-bearing, right?
Well, no, it's not. I mean, one of our early on lessons learned is the systems in California and some of our partners towards the east that used to be a health plan, those have been huge advantages because they were more adept at taking large amounts of population health data and making it much more usable, much faster. And part of the key with any of this kind of work, when you're talking about the size of our populations or the size of the state's population, is getting a handle on a pretty large, complex set of data. And as you've heard me say before, I think trying to manage a business with claims data as your primary source, that's not ideal for anybody. That's really hard, and it's fraught with challenges.
So how have providers responded? I mean, you're asking them to shift toward a more risk-bearing posture, and to address your criteria for outcomes, all in the context of a triple aim style but this is dangerous stuff for a provider. So on the other hand, you have no real interest, I presume, in putting providers out of business. So the question is, how have you partnered with them? Have you together negotiated some risk sharing, or?
Absolutely, yeah. And we've evolved, how we did this from when we started, and we'll constantly need to evolve it. I mean, I think in the future, the key to this will be much more complex financial arrangements than we've even fathomed at this point.
Oh, okay.
But we'll learn and we'll get there. I mean, the good thing is we can be an insurance mechanism. We're big enough, and we've learned a lot about where we need to provide some help and protection. We've redone the way we account for high-cost claimants, for instance. It's been a really difficult thing to work through. But you know, if you want to make it work, you can find a way to work through it.
Right, especially when you're working at, that's one of the advantages of working at scale. So, okay, now the operating premise seems to be that if we can either blow up or at least modify fee for service and change the financing, that we're going to get changes in how healthcare is actually delivered. And your comments earlier suggest that that's true. So tell us more detail about your experiments. What you talking about, bright spots and maybe some things that haven't worked. And so what behavior changes in healthcare provision have you seen inside these models? Well, and what do you think the learnings are so far?
Well, that's like a lot of questions.
Yeah, right. Well.
Okay. So first of all, we're doing all this within the current construct of the payment system. I think too many people let that become much too big of a barrier. I don't think any one of us are ever going to, change that dynamic ourselves. So we look at these as business-to-business relationships, and our health plan plays a very important role because they still hold the provider contract, they still pay claims, they do all these important things. It allows us to still, meet the requirements, the IRS requirements of a high deductible plan. I mean, there's all kinds of things you need to work through, but I would say our goals are really, really aligned, related to affordability, quality, and service. And when you change that paradigm, you start looking at things completely different. In the fee-for-service world, ER visits are revenue. They're pure revenue. If I was paid the way most systems are paid, I don't know that I would do anything different. But now, I can't. Some of our learnings are amazing, and way beyond the limits of confidentiality to share all the bright spots that we've seen. But I can tell you a fabulous story about a colleague of mine. Her mom is covered under Boeing retiring medical, has a lot of health issues, was a member of one of our ACOs, lost her care provider, couldn't find one. My colleague reached out to me and said, hey, my mom's a member of your ACO thing and it's not working. I'm like, okay, tell me what's going on. And within minutes, we had somebody from one of our partners reaching out, with a list of providers in the community that they could get my colleague's mom into. The really cool thing is, to me, and the reason I always tell this story is my colleague's mom had a cold, kind of like I do, and she wasn't answering her phone. And so after 2 or 3 days, our ACO partner wanted to send somebody to her house. Hey, that's really awesome. Now, luckily, they reached out to one of my team and said, hey, should we send somebody to this person's house? And I was able to reach out and find out she just had a cold and she was fine. But that's like a level of service that I believe is kind of game-changing. We all know that if folks with very complex conditions don't have the right provider-clinician relationship, bad stuff can happen. They can end up in the ER, they can whatever. Here was a provider system that wanted to go to this person's house and make sure they were okay. As an employer, what more could you want? Those are the bright spots where we have, you know, just so many fabulous examples that are, I think.
So let's tell us some more examples here of behavior changes by providers that you've seen as a result of a moving toward a value-based or ACO model.
Sure.
So, I mean, the first thing is they asked how she's doing without suggesting what the billing code was going to be, I guess, right? That's a big step forward.
Yeah.
What other kinds of behavior are you seeing?
Well, there's an intense focus on our population and really figuring out what's going on.
Healthcare? Healthcare doesn't know how to spell the word prevention. What's this about?
Well, and there's other factors beyond just the typical healthcare stuff, other social determinants, all kinds of other things that you can look at. So there's a much broader focus on how to improve the health of our population. There's just a much different mindset on, at times, of, you know, what's important and, you know, how care is delivered to enhance the experience for our employees. I don't know how, I mean, it's kind of that simple. The focus is, one of our medical directors at one of our ACOs said early on that he had a physician ask him, should I be practicing as a fee-for-service doc or an ACO doc? I don't know what the answer was, but I was really glad somebody was thinking about that, because that meant there's this change that's going on. I think from, you know, really important things related to prevention, or like measures related to depression and obesity, a lot of those things weren't even being measured. They're now being measured. Is everybody measuring them? No. But is there an intense focus to measure those things and ensure people are getting the right referrals? Absolutely. Our folks figure, I mean, one of the things that was a bit of an aha to me was how important it is in taking this big amounts of population health type data, and it's not particularly helpful data unless you can get it to the clinician who's actually practicing care and build it into their workflow. If it's built into their workflow in a logical way that doesn't hinder their experience with the patient, we have seen fabulous change, because I think in the things that we're measuring, the physicians want to do that, but they need the systems and processes to support that and make it easier. But we're seeing that happen. Now, I was a little shocked at how long that cycle time was of, hey, we've identified a problem and we need to figure out how it gets into workflow. But I would say we're seeing progress and focus on that is, in my mind, extremely meaningful. I mean, how can we ask anybody to measure something if there's not a process that works effectively in the way they're practicing medicine to do it?
So you say you're seeing bright spots, progress, successful experiments. But in the background, this has got to be so tough for providers. I mean, I think of providers as essentially running two business models simultaneously. They got a fee-for-service business, which is probably the vast majority of what they do, and now they got to run an ACO model. And oh, by the way, the ACO model means they have to bear some risk, which is completely outside their experience portfolio for the most part.
Yeah.
But it's happening. So now, what are we learning about?
I didn't say it was easy.
No, you sure didn't. But and you say that when you get it going, you do see changes in care, and maybe the triple aim is advancing. That's hugely encouraging. Now, any learnings about what doesn't work, or where people are stumbling, or?
Yeah, lots. Behavioral health has been really challenging, continues to be, because there's, I mean, at the core of it, there's just not enough of certain providers, and at least I think it's probably a challenge in many communities. It's in particularly a challenge where we've done our ACO approaches. So we're working to try to fix that. I mean, one of the I think other fabulous thing that we've done and we've seen, so right now we have 5 ACOs in 4 locations. This is year 3 for the Puget Sound. So 2 years ago we did an ACO summit, brought everybody, all their leadership together to share lessons learned. And I would assume a bunch of folks here know Mark Avery at UW. He's done all kinds of fabulous work and research related to behavioral health. And he shared, the results of their research and what they've done. And this last year at our ACO summit, 2 of our other partners talked about how they looked at what Mark shared and adapted that to their system of care. They didn't do it the same way, which is fine, but they did it. That's been another very, very enormous positive learning. I mean, on the other hand, we'll have 4 ACO partners starting next year. Prov decided they didn't want to continue doing this, which is okay. I mean, we have to be aligned in our business interests, and it's okay if things don't always work out. I mean, I don't know how else, if everything always goes well, I don't know what you're going to learn. If you generally, if it doesn't work perfectly, you learn more.
Yeah, oh yeah. And negative data points are still a good experiment.
Well,
so
they're really important.
Yeah.
And one of the things that Arnie Milstein said to me, many folks know Arnie's at Stanford now, based on their work and their research, leadership and culture are the 2 most powerful predictors of ACO success.
Really?
And if I go back and think about, the importance of those things, even within our company, and then, think of how much leadership some of this change takes, I'm more and more convinced that Arnie's absolutely right on that data point.
So your comments, Greg, make me think that you're supporting the premise that purchasers, like Boeing, have a role that they can play if they choose to
Absolutely.
really enable experiments, drive change.
Absolutely.
Now, is Boeing all alone in this? Who else is, how widespread is this interest in, as I say, doing experiments with ACO models?
I mean, I never like to speak for others. So where, I've seen significant change is especially in, organizations like the Pacific Business Group on Health and all the employers that are members of that, and leverage PBGH to then help make things come to life as products. So, I think of there's many employers taking advantage of their centers of excellence approach, and I think have seen some, really strong success there. David Lansky's here somewhere. He could share. Where is David? Oh, there he is. So people can ask him later. I mean, not everybody has this. We have very large footprints in certain communities. There are other employers that don't have that.
Right.
But the principles, whether you apply this to a Centers of Excellence or an ACO, are no different. I mean, you're changing the way you're paying for the care. You want an awesome level of service, and you want to make it more affordable. I mean, I have a postcard from an employee of ours that went to the Cleveland Clinic, and in it, he told me how fabulous the housekeeping staff was to him when he was there. I thought that was pretty awesome. And the gentleman sent me a note saying, thank you for this experience, let alone the awesome care he got.
Right.
But the improved experience was really, really important. So, I mean, we're seeing a lot of really good work through, PBGH and some of the things they're doing. And then, well, it's much more East Coast driven. The HR Policy Association which is a group of very large companies and their HR leaders are rolling out, in various cities where there's a large population of those employers, kind of a joint collaborative kind of an approach to participate within an ACO. So while I wish every employer was as demanding as we like to be, that's somewhat unrealistic, but is there more and more energy being placed in, I think, the right place to encourage this? I'd say a couple years ago, I was pretty discouraged. Today, there's still a lot of work to do, but I think there is many, many more folks focused on this.
Okay, so if the power and expectations of the purchasers are really starting to have an effect, and we're seeing experiments at scale, and providers are starting to change how they practice, what's the potential for innovators to be constructive in this? We tend to focus on the financial models and say, well, the financial models will drive changes in practice, but then we really need changes in practice, and that isn't just a matter of attitude. There are innovations that can help, innovations in business models, in technology, and so forth. What are you seeing, or what do you sense is the potential for the innovation community to really help here?
Excuse me. Well, from a number of respects, it's going to become a much, much more powerful part of this marketplace. I mean, I think as expectations are changing in what we expect, then, either systems or providers are going to need help in meeting those expectations, which creates a much different marketplace and creates, I think, a much higher demand to innovate, whether it's via service, quality, or data, or whatever. I just think it changes the dynamic, and those that are, that have good products are going to see more and more uptake and opportunity. I think there's some really, really key areas that can make an enormous difference. And I'm seeing more and more players in the data space, and I can't say, I could say it 1,000 times the whole industry needs to get just so much faster with data and predictability and reliability, and looking beyond just claims, looking at other economic factors, and helping get that data to the clinician dramatically faster. I mean, one of the big things that we're trying to leverage more and more is pharmacy data instead of just typical claims data, because you can see it almost as it's occurring. So you can see the results of an employee purchasing a medicine almost seconds after it occurred. Where with claims data, you're generally waiting for a long time. So I think there's just huge leverage opportunities for folks that can really figure out this data thing and do it dramatically better. And then I think the other really big missing element, and starting to see a little bit of movement here, but still fewer and fewer folks are pulling in quality into that equation. It needs to be, especially for the employer community, it's got to be front and center. And while I understand there is somewhat limited data, there is still a lot of data that's not utilized as effectively as it can be.
So you mentioned to me appropriateness.
One of my favorite things.
Is it? Well, I want you to tell us a little bit more about it, because I mean, the implication is that in your model as a provider, you would value me telling my patients that the procedure I normally offer wouldn't do them any good, and therefore let's avoid the.
Wouldn't that be awesome?
But are you going to actually reward me or even thank me for declining to serve a patient? How does this work?
I mean, I think in an ACO model, you have the opportunity to do that. You have the opportunity to balance out, revenue loss or revenue gain. I think in bundled payment approaches, you have the ability to pay more for a better level of care that includes that, that portion of just determining whether it's an appropriate procedure or not for the patient. I actually have no interest in pure kind of bundle models. And I know there's lots of issues you need to work through, but we can pay for the time and energy that it takes to do that review, to do it right, I mean, it shouldn't be a financial decision whether it's an appropriate procedure or not. So you have the ability to work through that. I've told David in the Centers of Excellence model and in bundles, and I know there's really challenging stuff to work through, but why aren't we providing within that arrangement something for hospitals and rural communities to send their patients to places where there's better outcomes? I think we should be doing that. But I think until you start to kind of get into the details of how these things work, you just continue to have unintended consequences. So,
listening to you, I've got, if I put my innovator's hat on, I can imagine I'm going to come up with a product that's going to use big data to help ACO providers deal with their risk-bearing responsibility, because they're not exactly historically well equipped actuarial leave to do this, but I could help them with that. I heard you say maybe I can do some data and data immediacy things that would actually help physicians practice in this new model. Maybe I could do something in behavioral health that would, since now you're expecting the providers to do better in behavioral health and they don't have very many good tools, maybe I could really help them there. Any other what are they struggling with that innovators might be able to help them with? Any other ideas?
Well, I want to make a point related to what we've been talking about, because I think there's a lot of products right now in the marketplace that are trying to do things outside of how care is typically delivered. I think in the end, many to most of those won't be successful, and the key is to enable the clinician to do what they want to do, easier and more effectively. I do see some neat examples related to kind of pure lifestyle things where, it's so behavioral, and you can leverage technology so much that there's probably some opportunity. Oops, sorry. But I think the real opportunity is to do things in partnership with clinicians that enhance their ability to manage a patient and a population. So to me, that's really, really important. I go back to, anything related to enhancing service. I won't name names, but I had this fascinating discussion, and it was a good learning experience, and I'm sure one of my ACO partners appreciated my opinion, but I told them I thought it was just stupid that they give people MyChart accounts if they didn't pick a primary care doc. It just drove me crazy. I wasn't asking anybody to do anything clinical. I was just trying to help them figure out how to engage with a population that doesn't want to engage with traditional ways of getting care and wants to engage electronically. That one just drives me crazy, because we know how much of our population wants to interact via their smartphone, and that's going to be the first place they go for an interaction. I would say, for instance, in this community, we're so wed to Epic, and MyChart, and it allows for interactions to occur. Is there an enormous opportunity for a much better experience? Absolutely. Oh, I was shocked the other day when I realized that my physician's picture was showing up in my MyChart account. But right now, even within our ACOs, you could have to have multiple MyChart accounts to communicate with all of your physicians within one given ACO. From a pure consumer perspective, that makes no sense whatsoever. I cannot believe that via technology that cannot be solved. I actually have providers tell me, and this is just fascinating, but I have providers tell me that they're not allowed to communicate via email. That doesn't meet, I actually had somebody tell me it doesn't meet privacy requirements. So I asked the provider if they knew what my chart was, but I mean, I tend to rant and rave, and I shouldn't, but if the experience is really, really good, it will engage people, and it will engage people to participate in their care like they have never participated. And we have to be willing to engage folks how they want to be engaged.
And that has a huge potential for better population
Well,
health.
I mean,
and if I'm getting
yeah.
paid for a population instead of for a procedure,
Then I get focused on those
right,
things.
okay, then I get focused. All right, this is back to my alternate title. This is Purchaser as Provocateur. And it sounds like it's got some momentum here. Let's pay attention to the clock and maybe open this up for questions from the audience here. This is interesting and I think provocative. Just what is the potential for purchaser interests and criteria to inform and enable innovation here? Let's hear your question.
So Greg, you talked about your arrangement with the Cleveland Clinic. Have the financial incentives been strong enough to move a large proportion of patients who need that procedure to take advantage of the Cleveland Clinic services? So isn't that often one of the kind of challenges, is kind of getting the patients to kind of uptake?
So I would say for us, no. I think there are examples with other employers that don't have as rich benefits as we do. It's more challenging. It's harder to make things less than free sometimes. So we have some challenges with that. So we try not to make it about an economic decision, but more about it's one thing that you should think about if you need some very, very significant surgery. But I have also seen results from other employers where that economic choice, that incentive might make a bigger difference that I think has been really, really positive, because now there are more patients going to facilities that have measured their results, are meeting that clinical criteria. They're applying appropriateness. I love the work that VM is doing as part of what David and PBGH does, and they just published a piece related to spine surgery where I think it was 58% of the patients referred that thought they needed it didn't need it and needed something else. I think that was really powerful.
But have you been able to make it attractive in other ways? Or are you
Yeah.
kind of limited by the financial?
Yeah, absolutely. We end up doing things like paying for people's flights and making it. There is. I would also say that this is part of what I view as a healthcare supply strategy, because to me, it's way better when local systems of care meet the quality and performance levels that they are very transparent about at the Cleveland Clinic. To me, that's better, because then somebody is getting care within their local community, and then there's, because there's other challenges when you're getting a procedure done not in your local community. So, you know, there's some really cool things we've done from that perspective as setting it as the benchmark.
Greg, I have a question. You touched on economic development in a way, on how it has created a competitive advantage potentially from Boeing to competitors. Can you elaborate on if that was part of the strategy going forward?
I mean, our strategy is much more around attracting and inspiring our employees. I mean, I would say in our world of competing globally for both talent and to be affordable, we need to constantly make sure that we're being affordable. But I'd say we're more focused in helping be affordable around productivity and improving health. And we've actually demonstrated in a cohort that we've been following for a while that, you know, we've helped our employees become healthier. But it's more about that part of it than, you know, just a pure economic piece.
Okay, so the question I have is, I've studied quality as sort of a healthcare strategy for a while in my career, and from the inside, quality discussions are still not really that nuanced. So I'm wondering if you can describe when you sit down across from your health provider partners and start talking about quality, start talking about the things you're going to measure as success. Is it, are you seeing sort of process of care, or is the gap between what you would see as those quality metrics, service elements, return to work, things like that, really, really wide compared to what they would be measuring? We would look at infection rates, disutility of care. We might look at ED visits that are avoidable, things like that. I'm curious if you maybe even give some examples, because I think that sort of bridging that, we were successful if we didn't kill you or give you an infection, versus we were successful if the patient returned to work faster, something like that. I'm curious to hear.
Well, I'll go back to something I said earlier. It's really important to align on what's important and what the goals are. So I would say the true answer to your question is sometimes we're really close and sometimes there's kind of a chasm. I'm not aware of too many folks that outside some of the integrated systems like Group Health or Kaiser or others who, you know, have really done well measuring things like obesity and referrals related to that. I would say folks have been really open to doing that and agreeing. I mean, it hasn't been particularly difficult to find common ground. But you almost have to look measure by measure. I mean, there's some things, you know, like hemoglobin A1C and other things that in some places they're already really done well. I mean, we have, in some of those things, we've actually seen improvements, but there was no, you know, there was easy alignment on some things related to obesity, behavioral health. The alignment really wasn't that hard, but there was not much of any measurement going on. So,
especially populations like oncology or, you know, some of these more chronic, complex patients, we don't have good measures, so it's hard to know.
but I think the power has been in we can evolve what we measure much more rapidly than typical by, you know, really understanding our population and then focusing on those things. It also, I mean, I've been told by some of our partners that they've really been able to leverage our work together as a change management tool. So blame me that this is important.
2 more questions.
This may be a question that you can't answer, but looking at the really big picture, you know, the United States gets a real negative grade compared to the rest of the Western world as far as our costs usually double, and our outcomes, we're losing out on several sides. With your history of Airbus and you sort of are dealing with a completely different supply system there. Do you see it as bad a grade as it's given from the Boeing perspective, or do you feel like there's a?
I think that's a wonderful question. I wish I could answer it, and I don't really know. Yeah, sorry. I wish I did. Many of our global populations are growing, but they're really relatively small.
All right, Joe.
Greg, I'm with Point B on the capital side, and we have about 1,200 lives. We're self-insured employers. And when we called around, based on the example you've set, and tried to set up our ACO, nobody called us back. So we have a few less zeros that we're managing in terms of our balance sheet and our leverage in the marketplace. So we made an investment in a startup called Carum Health, and they're trying to aggregate small to medium-sized employers to try to take advantage of the bundled carve-out. And one of the things, I was just at their board meeting, and they're signing up providers, and they're getting employers really excited because they have no control, the smaller ones, over their spend, and they don't have big HR departments and the resources you have. And so they're getting traction, but when it goes to the employer's managing lots of benefits and getting, that physician-patient relationship to consider the Carum carve-out, where they're getting concierge services, their net promoter scores, the people that use it love it. It's terrific, and they're trying to be more local. They're trying to find providers that are local, not having to get on airplanes and fly around. So we're addressing these issues, but do you have a suggestion or recommendation for this technology startup that's trying to be kind of like Expedia-like experience for, booking your healthcare as opposed to a hotel? They're doing the right things, except the utilization is probably not where they'd like to see it, because the employer can't do much to really direct that employee to help them save money and get a better outcome.
Well, I have 2 quick thoughts for you. One is our finance organization has been a wonderful partner internally to me in helping to make some of these things priorities. And I often think, especially at smaller companies, a focus on engaging with the financial side of an organization can be an effective strategy. I have, in limited situations, seen that be successful. I think for smaller companies, and one of the other things that we're really, really exploring, I think a really, really big key is primary care. Not necessarily how it's been defined typically, but I think when those relationships are there, they can be enormously powerful in getting people to the right place. With all these other goals. And as we look at, kind of ACO models in some of our smaller communities, we're really, really focused on primary care partners and how can we do what we've learned on a smaller scale, but through that avenue.
Okay, this is a good chance to wrap up, but I would remind you all that thanks to the Grove, we have refreshments and more opportunity to corner Greg with even more pesky questions. Thank you again for coming. Please help me thank Greg.